right? Can he tell you he's one of my students? It's amazing I could teach people younger than me and older than me.
I said that you were going to follow him, and I scared him. He was like, I got to make sure I get done before.
I can train, keep them trained. Okay. All right. So overdose. There may be overlap. I'm just going to go through them anyway. So overdose, very, very common. Unintentional overdose is leading cause of injury-related deaths in the United States in your age group, 26 to 64-year-olds. More than motor vehicle accidents every year, so it tells you how many. I worked at the ER when I was a resident, and that was just Friday and Saturday, that's all we saw. Mostly what we saw were overdoses, because we were close to the University of Texas campus. More than 200 people die every day in the United States of an overdose. Most half of those are narcotic, or opioid abused. So very common. So activated charcoal, have you talked about that?
Yes.
All right, we're going to do it again. Okay, so why do we call it activated?
It has fallen out of favor.
Activated charcoal is not. Now, Ipecac has. Surface area. Why did they say they've fallen out of favor? It's still one of your #1 gut decontamination. That is true. So 1 dose is now the recommended. There are a few places where you'll use multi-dose, and I'll give you those indications. Activated, what they mean by activate, as opposed to the charcoal that you burn in your little grill outside, it is activated by gases which really increase its surface area. So, here's a picture of activated charcoal. So, we want to get it in while the toxin is still in the stomach, because you don't absorb anything out of the stomach. So, you got about a 1 to 2 hour window. There is some controversy about its benefit once the toxin has moved into the small gut. But for the most part, it's recommended shortly after someone has ingested a toxin. So you see its makeup there. It is got tons of these little channels that form different pores that can then adhere toxins to the surface area. Where else do we use charcoal? What other things are in charcoal? What other things do you use every day? They've got filters that are made with charcoal.
Like air filters?
I bet your coffee, your water, filters, aquariums. So a lot of the little filters that you use are charcoal because its surface area is so big. Just to show you how big, 50 grams of charcoal is an adult dose. This is 50 grams, okay? That will cover the surface area of the land I own. We own 12.2 acres, that's 13.7 acres, 50 grams, enough surface area to cover that. That's a wow. Okay, so that's why it's so effective. That's why I was surprised when you said it's fallen out of favor.
Well, I guess he said it's hasn't been improved since it first came out.
That's true.
And
It's pretty much the same as it used to be.
Okay, where's my inspiration? I thought you also said something about obstruction, like the multiple doses that they were giving.
Yeah, they can accrete in the stomach. They can cause blockages. So that's true. So pretty much 1 dose. All right, so let's see, activated. Let's go under it. Catch up with myself on here. So there's the, under activated, 1 dose, usually a gram per kilo, but I'd say most people don't go by that. Most go by amounts, and those are listed down at the bottom of the page. But you should not use it when you've got non-toxic ingestions, not for just the hell of it. So we just don't do it because we don't know what else to do. If their poison has moved on past, if they are quite delayed, then there's other things you're going to do. Poisons that aren't bound by activated charcoal. So some drugs will not bind it. I've got it down through here when you would not use them. When aspiration risk is high, so you don't want to get that charcoal down in the lungs. So when is it indicated? When the toxin's still in the stomach, 1 to 2 hours. Potential benefit of activated charcoal once the stomach is left, again, controversial. Contraindications, decreased mental status. So opioids, we don't use them because they do quickly change mental status. Late presentation of a poisoning. Increased risk and severity of aspiration, like with a hydrocarbon, like if they've got gasoline. Kids suck gasoline down. Need for endoscopy. Toxin poorly absorbed, iron, so we don't use it with iron, just doesn't adhere. It's too charged. In the presence of an intestinal obstruction, it will just make it worse. So there's the dose, usually in a 10-to-1 ratio. I would like you to know those doses. You should have some sense. So for little kids, 10 to 25 grams. Children, 25 to 50, and 12 and above is 50 grams. So a bottle of activated charcoal, and it pretty much comes as made up already as a slurry. It is a mess. It's just a mess to get. So it comes this way in sorbitol. You can mix it with other things, but you have to be careful. If you mix it with water, it's really gritty and it's hard to get down, just because of the texture is so foreign. Mixing it with other things to make it palatable can decrease its absorptive capacity, so be careful about doing that. So the sorbitol is great. It is a very good vehicle to keep the activated charcoal in a liquid that can be mostly easily absorbed. But on the other hand, what's the problem with sorbitol? It's diarrhea. So in little kids, the rule is if you can avoid it, don't use the sorbitol. But if you are, you only use 1 dose. Because the diarrhea, especially in a little kid, high volume, especially depending on what you're treating, you can put them at risk for metabolic acidosis and potassium problems. So why do they get metabolic acidosis with diarrhea, big amounts of diarrhea? Because they excrete too much what? Bicarb. You have to excrete a lot of bicarb to cause a metabolic acidosis and diarrhea, but in a little kid that could happen. Adverse effects. Aspiration, you got a good ER, they hope you're good, and this is going to be unlikely. I never saw an aspiration of the years that I was in the ER, and we had really good folks who knew what they were doing. GI side effects, though, those are possible, because it's quite a volume that you're putting down, especially if they've eaten around the time that they ingested the products as well. So fullness, abdominal pain, nausea, vomiting, constipation, black stools, bowel obstruction, diarrhea more likely due to the sorbitol than it is to the charcoal. Okay, so when might you use multidose? If you have a drug that is excreted in the bile, then what happens is there is this cycle we talked about before, the interrupting hepatic interro cycle. So what happens with drugs that are soluble and excreted with bile salts by the liver, they get excreted into the intestines, and the intestines reabsorbs most of those. So the bile in your gut, for the most part, is recycled. You don't excrete very much in your stool. So that can be the same thing that will happen with a drug that is soluble in bile. So that is a case where you might use multiple doses of charcoal. They're listed down there for you. Carbamazepine, Dapsone, phenobarbital, quinine, and theophylline. These are not very common drugs anymore. So I would say for the most part, you remember the rule of one time. One-time activated charcoal dose. On the top of the next page, there really isn't a lot of data on what the dose should be. So that is probably going to go to experience. Here's a recommendation of 50 grams every 4 hours, or 25 every 2 hours. So there really isn't anything out there that will guide you like it is with the sample. If you're going to use multiple doses, they recommend you don't use the one in sorbitol, just because of the risk that associated with a lot of sorbitol, especially in young kids. Okay. Now, here's your outdated treatments. So syrup of Ipecac we used to use a lot. Your parents ever give it to you when you were little kids? No? Okay. Well, we used to do this. We used to, when somebody came in, that was the first thing we do. If it was recent, or I worked the poison center that Scott was in when I was first came to Oklahoma, and we did that a lot over the counter. We would tell parents, get it, a lot of parents kept it at home. Lots of prenatal classes would teach parents to keep it, and we would tell them how to give it. So we don't do that so much anymore. One is it's just not as effective, and the risk of things that can happen if it doesn't go well is higher than what you get. So we don't recommend it anymore because it's unpredictable, adverse effects are higher, and it can delay treatment. Cathartics. So the idea with the cathartics is if you can't get them to throw it up, then you can get them to poop it out. So we're just going to rapid transit your gut and try to remove it that way. Well, that doesn't always go well either. So that is not recommended. Mag sulfate was used and recommended. So there's lots of problems with mag sulfate and people who have kidney problems. So we don't recommend doing that anymore across the board. All right. Questions or anything I told you that he told you differently? Okay, Tylenol. I'm sure he talked about this one. We're going to talk about it again. It's one of the most common ER or reasons for poison center calls. I found one thing that said more than 100,000 a year in terms of Tylenol. 56,000 ER visits in 2016 due to Tylenol. 2,600 hospitalizations, 450 deaths. So that goes to good, just good treatment. Probably smaller doses too. If you work with pediatric population, young moms, women of reproductive age, you have to talk about medication safety. And with your old patients, you've got to talk about it because that's what happens, is that kids get into drugs, especially when they're not stored well, when they're not stored properly, like they take off the safety cap. So safety caps have not been always part of prescriptions. That probably only came about probably in the late 70s. And a lot of older people don't like them because they're hard to get off. So they may take them off themselves and dump them all into another product, and then the kids find them. So have those conversations with your folks depending on what stage of life they're in. So I don't like multi-ingredient products, and Tylenol is no different. It's in over 600 products. I really don't like it because people don't realize it's there, and they can get a lot of it from multiple different sources. So here's a story of a guy that came in when I was a resident. It was morning report, and the residents were giving a report of a person who had come in the night before and had taken too many Darvocet N100s. Those are no longer on the market. Propoxyphene was the drug in there. It was the opiate. But it also had Tylenol in it. The N100s had 650 milligrams per tablet. This guy had consumed, they thought, about 100 tablets of that over about a 5-day period. More than likely, it was an acute ingestion on top of chronic taking. He kept upping the dose because he couldn't get pain relief. So I asked, what was his acetaminophen level? But they didn't get it done because they just overlooked it. So it is a common thing to overlook and forget that Tylenol is a problem, or is part of it. One thing I would tell you is to always have a very high suspicion for Tylenol, especially if you suspect that it is a multi-drug ingestion. Okay? Because it hides everywhere. Percocet has Tylenol in it, or acetaminophen. Tylenol number 3s, Vicodin, Lortabs, they all have got Tylenol in there. So don't forget about oxycodone commonly with Tylenol. So most of those narcotics are mixed with a combination, either a salicylate or acetaminophen. So always think. It doesn't hurt to get an acetaminophen level when you're drawing your tox screens or you're trying to figure out why they're so sick, or you know that they've taken overdose. That man, when finally they got his, I don't remember what his level was, but his liver enzymes went to above 10,000. He lived, and I don't know how, because he was so sick. He just about killed off his liver. And there was a delay because they didn't think about it. They didn't think about the acetaminophen part of that drug. See, it's not in the, what would make you even think about it? Most drug companies use that little set part as an indicator of acetaminophen, Percocet, so Darvocet, but just didn't ring with the resident that night. So if the overdose is identified early, mortality is low, and that it shows you in the stats I gave you, 56,000 ER visits, 458 deaths. We are lucky is that it does have a specific antidote, so we'll go through that as well. So look under the kinetics. So pharmacokinetics, you should know this in your sleep. The dose for a kid is 10 to 15 milligrams per kilo per dose. Okay? For an adult, the top amount in a day is what? 3 to 4 grams. Okay. So look at wind toxicity. So there is a wide margin of safety. The single ingestion of 250 milligrams per kilo. Okay, so you're comparing that to what a child's dose is. That's, you still got quite a bit. 12 grams over a 24-hour period. The man that I told you about took in about 65 grams over a 5-day period. Liver toxicity occurs in everyone who ingests more than 350 milligrams per kilo. So it's one of the things you're always going to draw when you suspect acetaminophen overdose. So peak levels at 4 hours. Now that's for the immediate dose. So one thing you have to keep in mind is that often they're taking extended release. So what did you learn about if they took an extended release product, then what do you do with your levels? You repeat it. Okay. So about 4 hours apart, you're going to repeat. And if they took something with it that slowed the gut down, people who are intent, the ones who go in and take everything out of the bathroom cabinet and as an overdose are nightmares. And some of it's because they slow their gut down. And so that drug can just sit there and get absorbed for long periods of time. So a serum concentration of acetaminophen is 10 to 20 micrograms per mil. The reason to keep that in mind is if somebody comes in and they do not know when they took the drug. So somebody comes in with them and says, I don't know, I found them down, but I found these bottles beside them. So that is one thing to keep in mind. Yeah, so those numbers, and in the nomogram, it talks about if you, depending on if you're 24 hours out and their value is still above a certain range, then you should go ahead and give them acetylcysteine. So that's one thing to keep it in mind. Okay. So did you talk about the metabolism? Okay, so if you look on the next page, you'll see this slide. This one's important to remember. So acetaminophen's all metabolized by the liver. You should know that drop dead because we worry about people who are alcoholics and taking alcohol. We even recommend that they take less Tylenol in a day, like 2 grams, don't exceed 2 grams. Okay. So it's primarily handled by conjugation. That's those phase 2 interactions or reactions that we talked about in the liver, the first module. Okay. So you can either put a big glucuronide moiety on it or a sulfate. And why do we do that? Why does the liver do that?
Water soluble.
Makes the compound more water soluble, the kidneys can get rid of it. Okay. So those pathways have fairly big capacities, but in an overdose situation you can overload them. They have limitations at the high end. A little bit of the drug the kidneys can just get rid of. And the rest, a very small amount, usually gets converted to that N-acetyl quinonamine. So that is toxic, very, very, very active moiety that binds to hepatocytes and destroys them. So the body neutralizes them by slapping a glutathione on it. Glutathione is pretty much a liver's job. You don't really find it much in any other place in the body. So glutathione is made up of 3 amino acids. You know what they are? Okay, so cysteine is one of them. What? Glycine and I want to say glutamic acid, but I think that's right. Let me out of my brain. Let's see. Glutamate. Glutamate, so it is glutamic acids, cysteine, and glycine. The cysteine is the rate-limiting step. That's why we can use acetylcysteine and make more glutathione. So that's why you get overdose, you get liver toxicity, is because of the metabolic pathways get overwhelmed. You create a toxic metabolite that the body can't neutralize any longer. All right. Did you talk about the stages?
Just generalized, like non-specific to start with.
So the first phase is fairly non-specific. They can be pretty sick, but it could look like a lot of things. So nausea, vomiting, abdominal pain, sweating, general discomfort, pale color. Okay, so that looks like a lot. That could be a virus. Liver functions can be normal. They usually will go up towards the end of that end of that first day though. So look on the next page, page 2, stage 2, 24 to 72 hours. This is where the liver toxicity usually will become manifest. So their ALT and their AST will go up. You'll also get other signs, so if you check their prothrombin time, you killed off enough hepatocytes that they can't make clotting factors anymore, so their bleeding time starts to go out. So you have to affect a lot of the liver to start to see that. So that can happen. Kidney function can also go down, so it can look like an acute tubular necrosis. Okay? Go back and look at GU. In that module, I did a talk on acute kidney injury. And under it, we talked about acute tubular necrosis. The main cause of acute tubular necrosis is what? Pathophysiology. It's ischemia. It's one of the ways you differentiate it from other. So go back and just read through that. It'll help you remember. So that's what it can look like. So they can also complain of right upper quadrant pain, liver enlargement, tenderness over that area. So that's in the first 3 days. Stage 3 is where they will, if they've had a huge overdose that has been missed, this is where they are likely to die. So significant fulminant Liver failure will ensue. Kidney failure will happen in a large majority. The worse the liver toxicity, usually the more significant the renal toxicity. So jaundice, confusion, and encephalopathy, probably because they can't get rid of ammonia anymore. And so ammonia is a common cause, a metabolic cause of encephalopathy. So here, their liver enzymes can be in the 10,000 range. So again, you'll see their prothrombin time. If you did an INR, usually you're going to do prothrombin. That will be extended as well. They get hypoglycemic. Why do they get hypoglycemic? Are they eating?
No.
No, probably not. You've probably got some deep bit 5 going in. But what keeps you from getting low? Right now, you're not eating. Why aren't you all hypoglycemic?
And your glucagon.
Glucagon. Not glucagon. Glycogen. Sounds alike. So you got glycogen stores that you break down when you're not eating, right? And you release as glucose. You kill off enough of those hepatocytes, you can't do that anymore. You can't sustain blood sugar. So they can get, if you got big amounts of the liver affected, then their blood sugar is going to go down. So death in this stage usually multi-organ failure. So usually liver and kidney are the major part. If they make it past that phase, then they usually survive. So then recovery, but look, it's fairly long. So 4 days to 2 weeks, their kidneys will come back usually to baseline. They end up with a central lobular necrosis because that's where the enzymes for the P450 system are concentrated, so that's where the metabolic toxicity takes place because of the production of that metabolite. So clinical recovery can take, tissue recovery can take up to 3 months, so it will lag behind. They will get better and look better way before that. Kidneys also will, their BUN, their creatinine will come up, they'll look like they have an acute renal failure. But they will also, if they survive it, they will return to normal. Acetylcysteine doesn't help with the kidneys. That's mostly supportive. It's going to help with the liver toxicity. Okay. Sound familiar? Okay, so you looked at this nomogram, right? Okay, so the things about this nomogram, when do you use it? 4 hours. At least 4 hours. You're going to draw a serum acetaminophen level, right? It's usually, pardon? Acute single dose. So the gray signifies what? Toxicity, and that is an indication to give acetylcysteine, right? So it is concentration and time dependent, right? So you're looking at how long out from the ingestion and what's the level. Matthew Remek, famous, been around for probably 50 years. Okay, next page. So you can use activated charcoal with these Tylenol overdoses. Known or suspected. So look, they're saying that if you don't have any of this information or you're waiting on information, you can go ahead and give the activated charcoal if you suspect that they've taken as much as 7.5 grams. And you're within 4 hours of ingestion. So indications for N-acetylcysteine. So you're going to draw a level and look on the nomogram, see where they are. Or if you suspect that the ingestion has been greater than 150 milligrams per kilo. So it's giving you options if you don't have that data available. available right away. You can't, it is a fairly, it's a stinky drug, but it's fairly well tolerated. So you can always get somebody started. It would be better here to err on the side of over-treating them than to under-treat them. Here's another one. So that third bullet, patient has an unknown time of ingestion and a serum Tylenol or acetaminophen concentration is greater than 10. So this is just a common thing. Somebody, they bring them in and they're like, I don't know. I came home and I found them down. Common. If they have a history of acetaminophen ingestion and any evidence of liver injury, treat them. If they're delayed, so greater than 24 hours, somebody didn't find them. They didn't show up for work. Somebody went over and discovered it. And there's a history of or a suspected large amount of acetaminophen ingestion. There are people that you can call at these different, there are poison centers usually regionally all over the place, but there are some big ones like Rocky Mountain Poison Center is a huge one in our area. You can call, you can talk to a toxicologist, and they'll walk you through what to do. So you've got those kind of backups as well. Usually your regional poison center can then refer you on to another. Because when I worked at the poison center, we had lots of ERs that called us. Okay, what do we do? Here's what we found. Here's what we suspect. What would be the best protocol? So poison centers are used to doing that, and they will have usually like this one here in Oklahoma City is certified. All the people that work there have met credentialing, so they know where to send you from there.
So if you call the national number, does it just see which region you're closest to?
I don't know that.
Okay.
I don't know what their network is. I think that they're going to get you to the best help that they can. Okay, so we talked about N-acetylcysteine mechanism of action, so I'm not going to go back over that. So did you talk about the two protocols? There used to be lots of different ways that people went about this, and then the FDA stepped in and said, okay, we're going to approve two of these protocols, oral or IV, so you can give it either way. It's not very well absorbed, so you'll see a difference in dose. So if you look at the oral, it's 50 milligrams per kilo per hour IV. Where's the oral? Sorry, up there. Loading dose of 140 milligrams per kilo PO, followed by 70 every 4 hours for a total of 17 doses. That's classic. That one's been around for 50 years. But it's not very well absorbed. So that's why if you look down, then at the dose IV, it's about, it's at least half that, 50 milligrams per kilo per hour, and then down to 6.25 milligrams per kilo per hour. So a big difference. It stinks. It has a big sulfhydryl group stuck to it, and so it smells like rotten eggs. So sometimes it's just hard for people to take it down. And if they're really ill, you're going to use the IV. So there's the oral or the IV 20 hour. The other one is the 72-hour protocol. So you can see why a lot of people go with the IV. Pharmacy will have these. The other group that tends to use this a lot are respiratory therapists. They use it a lot because it's a good mucolytic. In fact, that's its main indication is a mucolytic in terms of upper respiratory treatment. Okay, so IV. So you see the side effects: vomiting, contraindication to an oral. So can't take it down. They refuse oral administration or evidence of hepatic failure. under adverse reactions, the one thing to keep in mind, like we did when we talked about IV iron, is that it has a high percent of anaphylactic reactions. So using it in an area where you have access to treatment for someone who has an anaphylactic reaction. For the nausea, you can use like on Dancitron or Zofran. If they vomit within 60 minutes of an oral dose, you should repeat it. Kind of things we've talked about with other similar concepts. Duration of therapy, the recommendation is to complete the protocol. But what we're wanting to see is their liver enzymes stabilize or improve. We want their bleeding time to go back to normal. We want their serum acetaminophen level to go down to nothing, as evidence that we have kept them from becoming toxic. If you get them in time and treat them early, prognosis is very good. Let's see, no deaths have been reported in any large studies when it was given within 10 hours of ingestion, regardless of how high the initial level was. This is a common one. I can tell you I saw it all the time in the ER, so if you're going to work in emergency medicine, you'll see it. I just kept that number with me all the time. I always had it in my pocket. I just had laminated and whipped it out because we saw it that often. The next page, these are up to date. They did a really nice job of just putting it in a table for you. So I think one of the good things is it just does flow. I wouldn't say I'm giving it to you to memorize the table, but I think it's really good in laying it out visually and step by step. Okay, questions? Anything I told you that he told you differently? Anything you have questions over?
I just have a quick question. So with that, giving the activated charcoal, does that ever, if you were giving the NAC by mouth, would it ever bind part? I mean, would you worry about the charcoal binding the
I
NAC?
don't remember us worrying about that. But we also mostly did a lot of lavage.
Okay.
So that probably was the reason why it wasn't so big of a deal. So, and I think they would do that. A good centers would probably be able to be well equipped to do that. Other questions? Okay, let's go ahead and take a break and we'll come back in about 10 minutes and we'll pick up